All right. So, hi everyone. My name is Dr. Neil Naik. I'm the Regional Primary Care Lead for the Waterloo Wellington Regional Cancer Program. And today we're going to be talking about the new HPV testing for the Ontario Cervical Screening Program and the launch date for March 3rd, 2025 in Ontario. Before we get started, I'd like to give a land acknowledgement. We gather today virtually from many parts of what is now called Waterloo Region. Traditionally, this area was a gathering place for many nations, and I acknowledge that our meeting today is situated on the Haldeman Tract, land that was promised to the Haudenosaunee of the Six Nations of the Grand River, and is within the traditional territory of the Neutral, Anishinaabeg, and Haudenosaunee peoples. We are grateful for this opportunity to live, meet, and work on this territory. We reflect on the principles of reconciliation and strive to incorporate them in all the work that we do. Because this is a formal presentation, these are my disclosures in terms of the implementation of the HPV testing. In regards to Honorary and Speakers Bureau, Merck has helped to organize some of the in-person meetings for this slide deck. And in addition to that, the Waterloo Wellington Regional Cancer Program employs me as the Regional Primary Care Lead. There is nothing else that is related to this presentation that is a conflict of interest. This program has received financial support from Merck in the form of organization of foods and events. And this program has received in-kind support from Ontario Health, Cancer Care Ontario, and the Waterloo Wellington Regional Cancer Program in the form of development of the slide deck, organization of the event, and accreditation. I do receive payment from the Regional Cancer Program, whose deliverables are being discussed in this program. Merck has a product that benefits from this presentation, and I have not received any payments from Merck for the delivery of this presentation. This program does not reflect the opinions of my opinions as a speaker, and was designed by Ontario Health, Cancer Care Ontario, using evidence-based content. There are many gender identities, and inclusive language can help screen eligible people understand whether screening is for them. There are times where the terms male and female are used, and when doing so, it is very much in the keeping of who has a uterus and who does not, who has a cervix and who does not. All right, for today on the agenda, we have a quiz, cervical cancer in Ontario, and about OCSP and where we're at, HPV and cervical cancer, understanding HPV testing, cervical screening terminology, new cervical screening recommendations, colposcopy, what happens after colposcopy, post-discharge, vaginal vault testing, case studies, and how can you change your practice? All right, let's jump into the quiz. So, question number one, and I want you to just think about these questions in your head, answer them in your head. Let's test your knowledge here. Approximately blank of sexually active people will have at least one HPV infection in their lifetime. It could either be 50%, 80%, 60%, or 20%. I'll give you a second there. Question number two, almost all cervical cancers are caused by persistent infection with oncogenic types of HPV. Oncogenic here meaning cancer-causing types of HPV. True or false? And then question number three, it typically takes blank for persistent infections with oncogenic types of HPV to develop into cervical cancer. And this one's a timeline, so it's either less than 6 months, 1 to 5 years, 5 to 10 years, or 15 to 20 years. Hopefully, while we go through this presentation, you can see what the answers are and see whether or not you're right or wrong. So let's jump back into cervical cancer in Ontario and about the OCSP. So about 530 people are diagnosed with cervical cancer every year, and 160 individuals die from it. Most cervical cancers are found in people who have never been screened or have been screened less often than recommended. So from 2017 to 2019, 35.5% of people diagnosed with invasive cervical cancer had not been screened in the previous 10 years. And this really shows the importance and how we know about the transition of pre-cancer cells to cancer cells and the importance of getting screened so we can catch this early. So the Ontario Cervical Screening Program is a population-based organized screening program. And the goal here is to reduce the risk of developing or dying from cervical cancer. And that aim is it aims to achieve this goal by increasing the percentage of people who get screened regularly and who have timely and appropriate follow-up when necessary. I think that's really key here in regards to how do we first know what the disease progress is, ensure that patients are aware of this in terms of getting their screening done, and then finally ensuring that they get that regular piece. And that is the beauty of an organized screening program, is that people are tracked over time in order to ensure that they don't fall through the gaps. It's how they get the reminders. It's how they're told that they need to get screening done. And this is incredibly important. And that's what we're here to talk about in population-based organized screening. We have our condition, which is, common and burdensome. We can detect it in the preclinical phase, and there's a defined population that we can test. Then you have an intervention. Is it easy? Is it acceptable? Is it safe? Are patients acceptable to it? And finally, it's the program itself and the infrastructure, with the coordination, integration. And then one of the most important parts here is quality improvement and performance management. And that's why we're having these changes today, is because we are going to go through a quality improvement phase change that will improve the way we treat our patients and identify them. And what we're trying to do is maximize benefits, minimize harms. So here we're talking about HPV and cervical cancer. So HPV infections are common, and 80% of sexually active people will have at least one HPV infection in their lifetime. That's going back to that question at the very beginning, where in that quiz, 80% of sexually active people will have at least one HPV infection. There are over 100 types of HPV, and 13 are known to be oncogenic. Oncogenic here means cancer causing or high risk. And those HPV types are 16, 18, and 45. Persistent infection with oncogenic types of HPV is the main cause of cervical cancer. So when that infection stays there, the body can't clear it. It doesn't have the immune system or the defense to do so. If it can't clear it, it causes cervical. It's the main cause of cervical cancer. And this is that natural history of cervical cancer. This is why we do the screening, because we want to catch them earlier than later. And this is your second quiz question: is it takes 15 to 20 years for a persistent infection with oncogenic types of HPV to develop into cervical cancer. So when you have that patient who comes in and says, hey, I've been with my partner for X number of years, the question also is, how many other partners have they had in the past? Because this virus takes 15 to 20 years of persistent infection to develop into cervical cancer. And so it still matters. And if they haven't changed or serotyped over, if they haven't had their vaccinations for HPV, it means that they may not have a defense to fight this, and it could still cause cancer. Vaccination is important. It's not the be all and end all. Just because somebody gets vaccinated doesn't mean that they don't get their cervical cancer screening done. It just reduces the risk. And so you can get normal cells that get infected, which can lead to low-grade cytology, and you can go backwards to just going back to normal, or can develop into precancer, high-grade cytology, and you could still go backwards to low-grade, but then your probability increases of that precancer becoming cancer at every step. And so when we look at the natural history of HPV clearance, we're seeing that more than 90% of infections get cleared, but 5% of infections persist. 3% of those infections progress to cervical precancer or cancer, and that's usually defined as CIN3+, or cervical intraepithelial neoplasia. And this happens, as we mentioned before, over a period of years. And so when we talk about the risk progression to cervical cancer based off of HPV type, we're seeing here that HPV 16, 33 have the highest risk of progress. Those above 5% is HPV 18 and so forth. I'm not going to read this off the slides, but you can see here that not all HPVs are the same, and that just because you had one doesn't mean you can't have another either, and each one has a different risk profile. So when we talk about the HPV testing here in Ontario, we're seeing that one-time sensitivity is significantly higher. at 96% versus that cytology test of 53%. That specificity is at 90.7%, and on the cytology, it was 96.3%. And so the HPV test detects oncogenic types of HPV. It checks for HPV. Cytology checks for the cell changes in the cervix itself. So when we go back to the pathogenesis of cervical cancer, the natural history of it, we're now testing for the HPV infection, which you can see here on the left, whereas cytology was checking for changes in the cells that were on the right. So we're capturing this at even earlier stages. And the interpretation here is objective and reproducible in the HPV test, whereas the cytology test had to be read and therefore was subjective. Now, for those who, it's been a while since we talked about sensitivity and specificity, going all the way back to medical school, residency. Sensitivity is the effectiveness of a screening test to detect precancer in people who have precancer itself. Specificity is about a normal result in people who do not have precancer. So if you guys remember, it's spin and snout. Snout rules out, sensitivity rules out, specificity rules in. So HPV has a higher sensitivity but a lower specificity in cytology testing, which is exactly what we want. We want to rule out those that don't have it. We want to capture as many people as we can to bring into this testing. We're talking about the negative predictive value of HPV tests. And so what we're seeing here is if you have a negative HPV test, how good is that to predict whether or not you have protection in the long term? And so the likelihood of a negative result will correctly identify people who do not have a H cell or high-grade squamous intraepithelial lesion or adenocarcinoma in situ in the And so finally, everyone else who is HPV positive for type 16, 18, 45, regardless of cytology results, or those who have another type of oncogenic HPV that's not 16, 18, and 45, but their cytology was high grade, or the second time around because their first cytology was normal, but then it went to repeat testing or referred to colposcopy. So specimens should be repeated within 3 months. A repeat specimen is not required, and referral to colposcopy if that person has a positive 16, 18, 45, and their cytology results are unsatisfactory, because remember, if you're positive for 16, 18, 45, you refer. Or there are 2 consecutive unsatisfactory cytology or invalid HPV test results, refer. And so when we talk about the use of intravaginal estrogen therapy, intravaginal estrogen therapy may be considered after one unsatisfactory cytology result in people who are using androgen therapy for gender transition and in postmenopausal people. As always, make sure you can talk to your patient about this and ensure that they understand why that's happening and why it's being used. Cessation. We've alluded to this before in terms of when should we stop screening individuals. So if you have somebody who is 65 to 69 years of age, and we're going to start off with the easiest one, they were never screened, then you continue screening. If a person did not have a cervical screening test from the age of 65 to 69, they should be screened until the age of 74. If somebody is HPV negative, then you stop screening. So someone can stop it if they've had one negative HPV test result, with the following exceptions. If they're immunocompromised, you keep screening until 74. If the person aged 65 to 69 have been discharged from colposcopy and have been advised to screen in 2 years, you should continue to screen until the age of 74. And finally, those who are HPV positive, and again, we're talking about oncogenic type, follow the screening pathway and refer to colposcopy if appropriate. So you can stop screening when they have a negative HPV test result or when they are at age 74, whichever occurs first. For those who are age 70 to 74, those with an HPV positive oncogenic type result, regardless of HPV type or reflex cytology, should be referred to colposcopy. Well, colposcopy is needed to exclude high-grade lesions. It's because at the age of 74, they're going to stop getting another test. Therefore, they need to have that excluded if they have an HPV positive result. And so that's regardless of HPV type. So we're talking about that 16, 18, 45, and the other type. OCSP does not recommend screening people at the age of 75 and older. Thus, if somebody has visible cervical abnormalities or is symptomatic, they should be referred for appropriate investigation to a gynecologist or gynecology oncologist. So let's summarize this. We're switching from cytology to HPV testing with reflex cytology. In terms of initial triage tests in the past, we didn't have any. Now, after the HPV test, we're doing partial genotyping and reflex cytology. We talk about the intervals. Previously, we used to say average risk individuals were every 3 years, immunocompromised individuals were every 1 year. Now it's average risk individuals are every 5 years, and immunocompromised individuals are every 3 years, again in the context of a negative test. When we talk about a repeat test, we used to repeat the cytology in 1 year. Now we're repeating the HPV test in 2 years. In terms of that starting age, there was age of 21. Now it's age of 25. When we talk about cessation age, cytology was 70 years if cessation criteria are met. Now, most people ages 65 to 69 with a negative HPV test. And we talked about those special circumstances as to when they would continue until 74. So let's talk about management of people under the age of 25. So the following will not, so testing is no longer offered after HPV implementation for those under the age of 25. And so the following will not be made available through OCSP as of March 3rd, once HPV testing is implemented. So standalone cytology as a primary screening test and screening for people under the age of 25. So when we talk about HPV testing for those between 21 and 24, for those who have started screening before HPV testing was implemented in OCSP, start HPV testing when someone is next due for a cytology test. Apply the new recommended intervals after their first screening result. For those who are 21 to 24 who started screening before the launch of HPV testing, so pre-launch cytology results if it was normal, then post-launch recommendations for those who are immunocompetent is that you delay the next screening until the age of 25 or in 3 years, whichever comes later. So if they had a normal cytology and they have an HPV test at the age of 24, it'd be 3 years after 24, therefore 27. For post-launch recommendations for those who are immunocompromised, you're going to delay the test to age 25 or 12 months, whichever comes later. In terms of unsatisfactory cytology, you're going to delay those who had an HPV test and unsatisfactory cytology, you're going to delay the next screening to the age of 25, or if requested, repeat the test at the patient's earliest convenience for those who are immunocompetent. For those who are immunocompromised, age of 25, or if requested, repeat the test at patient's earliest convenience. So the same regardless. If somebody has a low-grade lesion, an ascus or an LCIL with one, then or one result, then you're going to delay the next screening test to the age of 25. And then those who are immunocompromised, you're going to repeat the screening in 12 months. If the patient has had 2 low-grade results, refer to colposcopy. If they had a high-grade result, they should have been referred to colposcopy. And if they had a specific type of high-grade result, like SEC, ACCs, PDCs, you're going to refer to colposcopy or consider referring to gynecologic oncology centers if an obvious lesion is seen in the cervix. So, considerations for cervical screening in pregnancy. Pregnancy does not affect someone's risk of developing cervical precancer or cancer. Screening when due or overdue. Screen the patient when they're due or overdue for cervical screening. Defer to postpartum period for people in the 3rd trimester when there are risk factors for preterm labor or bleeding, or based on the patient's preference. The screening recommendations and indications for referral to colposcopy are the same for all average risk people, regardless of pregnancy status. So if they're high grade or HPV positive of the 16, 18, and 45, you refer to colposcopy, regardless of pregnancy status. Collection devices should not enter the cervical canal. That means your endocervical brushes should not be used. For patient comfort, cervical screening is usually avoided after 24 weeks and can be resumed as early as 6 weeks postpartum. For considerations with people with a double cervix, collect 1 sample from each cervix. A new collection device should be used for each cervical sample. Place in separate vials that identify which cervix the sample is from, right or left, top or bottom. But you're going to use a single requisition form for both samples. So bag 2 samples labeled right or left. You're using 2 sample collection devices for each one, not the same, 1 form. And so when you interpret the results, people with a double cervix will have a result for each cervix. And we'll get 2 result letters from OCSP. And they will get a single recall letter based on the most severe results. So providers should manage both cervixes based on the most severe results, following only the screening pathway, again, of the most severe results. So if one's an HPV negative, but the other one is an HPV positive of the other high-risk type, the low-grade cytology, then we're going to go down the pathway of the right cervix in this case. And then you don't just screen the right side, you rescreen both. And in this case, it's every 2 years. Colposcopy. There are 7 colposcopy pathways. And it all has to do with the different episodes of care. Most people will require 1 to 4 colposcopy visits in an episode of care unless persistent disease is found. And the goals are to discharge patients from colposcopy as appropriate, minimizing overtesting and avoiding overtreatment. So in terms of a high-level overview, a person who enters colposcopy could either be cytology of high grade or low grade. You have your initial colposcopy, and then they go through the histology, and it depends on whether or not high-grade histology is detected or not. If it's not detected, and your person who was referred with a low-grade cytology, they get discharged back to primary care. If that person did have a high-grade cytology and was referred in, and then the histology was negative, they'll go for a second colposcopy. If that's still negative, fantastic, discharged back to primary care. But if high-grade histology is detected, treatment in colposcopy and then post-treatment management, including a test of cure for at least 2 visits prior to being discharged back to primary care. In terms of that post-discharge from colposcopy, HPV and cytology co-testing and histology supports timely discharge from colposcopy. Discharge is important given the harms of over-management in colposcopy, and colposcopists are encouraged to provide clear recommendations on the post-discharge screening intervals. So when the person is discharged back from colposcopy, an average risk screening of 5 years or immunocompromised screening in 3 years, and those who are moderate risk will be 2 years. People at elevated risk will remain in colposcopy. When we talk about people, post-discharge and people not treated, those who had a cytology at the time of referral that was normal or low grade, then they will likely they will be screened in 2 years, and the second post-discharge interval, it depends on whether they're HPV negative, which case they go back to average risk, or HPV positive regardless of the type or cytology, which is a re-referral back to colposcopy. At the time of the initial referral to cytology at the first time to colposcopy, if that was high grade and they're found to be HPV negative at the time of discharge, then they return to average risk screening. If they're HPV positive post-discharge, regardless of subtype or cytology, HPV status at discharge, then it's a screening in 2 years. And then afterwards, if they're negative, then it's returned to average risk. If they're positive, it's re-referral to colposcopy. When we talk about individuals who were treated for HSIL on histology, what we're seeing here is HPV negative individuals, HPV results that are negative at the first post-treatment visit, and the status at discharge being HPV negative, then you return to average risk or immunocompromised screening, which is 5 versus 3 years. If, for example, their result on the first post-treatment visit is negative, but their status at discharge is positive, then the screening is 2 years. If they're negative afterwards, then it's 2 years. And then finally, if they're negative, they go back to normal. At any point, if they're found to be HPV positive for the oncogenic types, the ones that we're screening for through OCSP, then it's a referral back to colposcopy. And when we talk about those who had HPV positive in the first post-treatment visit, you're looking at screening in 2 years if they're positive at discharge. And then if they're negative, then it's screening in 2 years again, and then essentially return. So essentially, the long story here is if you have 2 negatives post-discharge, fantastic, you go back to average risk screening. If you get HPV positive in your post-discharge intervals, then you are, regardless of the cytology type, then you're getting re-referred to colposcopy. And we're seeing that here again, where you're seeing this for, now this is a little bit different. This is for somebody who has AIS on histology. This one is going to be 3 HPV negatives in order to go back to an average risk. And if they ever become HPV positive, you're re-referring to colposcopy. And so they've organized it into a table for us to make it easier. And so this is very much in terms of those who are discharged from colposcopy. It depends on what they had when they were referred in. It depends on what they have when they leave. And that determines what their next steps and the frequency of those tests are. So key takeaways. Some people can be discharged to primary care after only one visit to colposcopy. Some people may be HPV positive when they're discharged to primary care. And people who are HPV positive, regardless of the HPV type and reflex cytology at their 2-year post-discharge screening test, should be referred back to colposcopy. The discharge letter will have information on the next screening interval in primary care, whether or not the patient was treated in colposcopy, and when to refer a patient back to colposcopy based on post-discharge screening results. And contact the colposcopist if you do not receive this information or require clarification. Vaginal vault testing. So people who've had their cervix removed via hysterectomy are not at risk of developing cervical cancer, but may be at risk of developing vaginal cancer. Vaginal vault testing can be done to identify people at risk of vaginal cancer. And although vaginal cancer is also HPV related, the risk is very low in Ontario. So for the post-hysterectomy population, it's organized by risk of vaginal cancer and consists of elevated and low risk groups. So your elevated risk groups, people with LSIL, HSIL, or AIS histology in the cervix at the time of the hysterectomy, regardless of margin status or HPV status, and people with history of early cervical cancer, regardless of whether or not there was evidence of cancer or precancer at hysterectomy. And then your low risk group is anyone who does not meet the criteria for the elevated risk group. And that could include people with LSIL, HSIL, AIS histology in the cervix, but no evidence of it in the hysterectomy specimen, people with an unknown or no cervical screening history, including two-spirit people, transmasculine people, and non-binary people who did not receive cervical screening before their hysterectomy. Out-of-scope populations. So people with a history of cervical cancer beyond stage 1A1, people treated with radical trachelectomy, radiation, or chemotherapy, and people under surveillance in the cancer system. So when we talk about these elevated risk groups, we're going to perform a one-time HPV test of the vaginal vault 6 to 12 months after their hysterectomy. A reflex cytology is going to be done automatically, like it has been for the other ones, by the lab for HPV positive results. And again, HPV positive is for your oncogenic types, it does not exclude wart-based ones. If your patient's a low risk group, you do not perform the HPV test. So you may receive a discharge letter from a colposcopist or the provider who performed the hysterectomy if an HPV test of the vaginal vault is needed. But key note here, it says you may receive. So if you know somebody needs it done, please do it. Management of those HPV test results. So if they're positive, regardless of the HPV type or cytology results, you're going to refer that person back to colposcopy. If they're negative, no further testing is needed. And if it's invalid, we're going to repeat the HPV test at the participant's earliest convenience and ideally within 3 months. And if the HPV test is again invalid, refer back to colposcopy. So to go back a few slides here, we'll go back to point number 1, HPV positive, regardless of HPV type or cytology result, refer back to colposcopy. And the question is why? Well, it's because they were at elevated risk. So at the time of their hysterectomy, the specimen had LSIL, HSIL, or AIS. That's why. So when the HPV status is unknown before HPV launch, what's up with the management there? So if their most recent cytology-based vaginal vault test result was normal, no further testing is needed. If it was unsatisfactory and the criteria of vaginal vault testing are met, i.e. they're high risk, then we're going to do an HPV test. If those criteria are no longer met, then no further testing is required. If they were low grade, you're going to do an HPV test in 12 months. If they're a high grade on the last cytology, they should be referred back to colposcopy. And if they were high grade for SCC, ACC, or PDC, you're going to refer to colposcopy or consider referral to a gynecologic oncology center if an obvious lesion is seen. So in terms of guidance for vaginal vault testing, it was developed by Ontario Health in consultation with the multidisciplinary international expert panel. The use of an HPV test is approved by Health Canada for healthcare provider collected cervical samples, but has not been reviewed or authorized by Health Canada for the use in vaginal vault due to rarity. As such, a disclosure will be included in OCSP resources and lab reports in regards to this. We have a disclosure statement. I do need to read this out loud. So the use of HPV test is approved by Health Canada for healthcare provider collected cervical samples, but has not been reviewed or authorized by Health Canada for use in vaginal vaults. Vaginal vault testing is relatively rare, which makes vaginal vault specimens difficult to obtain. This means it is very challenging to obtain sufficient specimens to perform validation studies that are required to obtain regulatory approval. HPV test performance has not been specifically evaluated for detecting vaginal precancer and cancer in relevant populations, so risks may include a decrease in testing accuracy. Guidance for vaginal vault testing has been developed by Ontario Health, Cancer Care Ontario, in consultation with the multidisciplinary international expert panel, and other Canadian and international jurisdictions also provide guidance on using HPV test in the vaginal vault. The information provided by Ontario Health, Cancer Care Ontario is not intended to serve as a substitute for a clinician's professional experience, independent judgment, and decision making. Ontario Health, Cancer Care Ontario assumes no liability whatsoever for any errors or omissions associated with the information provided, and assumes no liability for any decision or action taken by the clinician or others in reliance on the information contained in materials. Just go over some case studies. So, case study number 1, somebody who's due for cervical screening. So Alex is a 28-year-old and is due for cervical screening. Her screening test result is HPV positive, other high-risk types, with the reflex cytology showing ascus. What is the recommended next step? Is Alex at moderate risk and she should have a repeat HPV test in 2 years? Is Alex at moderate risk with a repeat HPV test in 1 year? Elevated risk with a referral to colposcopy? Is Alex an average risk and returning to screening in 5 years? So moderate risk and repeat HPV test in 2 years. In 2 years, Alex receives a letter from Ontario Health reminding her to get tested again. Her HPV test result is HPV positive, other high-risk type with L-cell reflex cytology. What is the recommended next step? Alex is at moderate risk and we repeat again in 2 years? Or is Alex now at elevated risk and they need a referral to colposcopy? Or is Alex at an average risk and should return to screening in 5 years? I hope by now we all know that C is wrong. And in fact, the answer is B. Alex now has 2 HPV positive other high-risk types with also. This next step is a referral to colposcopy. And so Alex is seen in colposcopy, her cervix is assessed, and high-grade histology is not detected at her first colposcopy visit. Therefore, treatment is not needed. So post-discharge. 2 years later, Alex's screening test result is HPV positive, other high-risk type, with a normal reflex cytology. What is the recommended next step? Is it a referral back to colposcopy? Is it a repeat of another HPV test in 2 years, a return to screening in 3 years, or a return to screening in 5 years? The answer is referral back to colposcopy. Any HPV positive other high-risk type or 16/18/45, so regardless of type, is what I'm trying to say, should be referred back to colposcopy if they're 2 years post-discharge from the colposcopy clinic. Case study number 2. Sarah is a 68-year-old and has received routine cervical screening with the HPV test. Sarah is due for screening and the result is HPV positive other with a normal reflex cytology. What is the recommended next step? Do we stop screening immediately? Do we refer to colposcopy? Do we repeat HPV test in 2 years and refer to colposcopy if the result is HPV positive? Or do we repeat the HPV test in 2 years and stop screening if the test is negative? So any of these two are correct. So you repeat it in 2 years, and if the result is HPV positive, regardless, then you refer to colposcopy. If it's negative, you can stop. Zara is 70 years old and has not received cervical screening in a long time. She decides to make an appointment with her primary care provider to get a screening test. Her test result is HPV positive other with ascus reflex cytology. What is the next step? Is it colposcopy, stop screening, or repeat in 2 years? The answer is refer to colposcopy. And the reason behind that is what we talked about before, that this individual is 70 years old, they're HPV positive of the other type. They should be referred to have it eliminated from a histology point of view and potentially could stop afterwards. Ricky is a 22-year-old and is transmasculine who got screened just before primary HPV testing was implemented in the OCSP. His cytology result was a first-time L-SIL. HPV testing is now implemented. How and when should he be screened next? So A, delay rescreening with the HPV test to age 25. B, rescreen with cytology at the age of 23. C, rescreen with HPV testing at the age of 23. Or D, A or C, either are acceptable. So it's A or C. Because he has had L-SIL, you can either choose to rescreen the HPV test in a year's time at the age of 23, or you can delay it to the age of 25, and that's usually done with discussion with the patient. So A is preferable, but some people may choose to not delay and want to be rescreened. Mary is 49 with a history of cervical dysplasia. She's had a hysterectomy 6 months ago, and there was evidence of HSIL histology in the hysterectomy specimen. You perform an HPV test of the vaginal vault, and the result is negative. What is the next step? Is it refer to colposcopy, cease testing, or repeat the HPV test in 2 years? The answer is cease testing. Mary now has an HPV negative test. You do not need to keep testing. So, changes to your practice. So, the procured partners here. So, the test system vendor is Hologic, and the laboratory service providers are Life Labs, Dynacare, and North Bay Regional Health Center. And so, ensure that the OCSP tests are sent to one of those procured LSPs. If you already have an existing agreement with one of the procured LSPs, you can follow your regular approach for ordering supplies and transporting samples. If you do not have an existing agreement, the procured LSPs will reach out to support onboarding before HPV testing launch. In terms of ordering those tests, 1, confirm the patient's eligible. 2, collect 1 sample from the cervix, and remember if they have a double cervix, it's 2 samples, separate samples. Step 3, complete that OCSP requisition, 1 per patient, and label the cervical samples, and both if there's 2 cervixes. And step 4, submit the requisition and samples to the LSP. And so when we talk about eligibility, 25 and older who have been sexually active, you only need 1 sample, as reflex cytology will be done if they are HPV positive for the oncogenic types. You're going to be using that new specific requisition that's only valid on March 3rd and after. Providers will not be able to order the test on the Ministry of Health lab requisition or hospital requisition. And just a heads up, if you submit it before March 3rd, it will be rejected. And step 4, just submit it to the LSP. In terms of collecting the cervical sample, so you can choose one of the following options to collect a sample. You have a broom-like device or the endocervical brush spatula combination. Avoid certain types of lubricants, which can cause invalid test results, or use water to lubricate. This is really important because this is a change in the lubricants that we may be typically using. So the lubricant needs to be used is a dime-sized amount of water-soluble and carbomer-free gel lubricant. You're going to apply the lubricant only to the outer sides of the speculum blades. Do not leave any part of the collection device in the vial. So if you leave that broom that we typically do, that part at the very end that we usually separate from the stick in the vial, it will be rejected. And then we have to repeat the test on the patient. So you just put the broom inside, you smash it against the bottom of the tube 10 times, swivel it around, and then you take out the brush with the broom and throw the whole thing out, keeping the liquid, sending that off. Label all samples. It needs a patient's name, date of birth, and date of sample collection. And so OCSP uses thin prep systems for cervical sample collection HPV testing. So some of us may need to transition from our SurePath ones, the blue lids, to the thin prep ones, the white lids. Thin prep tests will be rejected if any part of the collection device is left in the vial, i.e., if you leave that brush at the end in the vial, they will be rejected. And in order to make sure that they don't get rejected, make sure they're not expired, ensure that the collection device, such as the broom, is not left in the vial, make sure the sample is legible and labeled. Make sure you complete all the required parts of the labeling. Pair all cervical samples with the corresponding requisition. Tightly close the sample vial to avoid leaking. If it leaks, they'll reject it. And ensure the sample is sent promptly to the lab. Additional instructions. If somebody is pregnant, collection devices should not enter the cervical canal, so the endocervical brush should not be used. For comfort, cervical screening should be avoided after 24 weeks of pregnancy or gestational age and can be resumed as early as 6 weeks postpartum. In terms of labeling, it's one sample from each cervix. For those with double cervixes, a new collection device should be used for each cervical sample, i.e., don't repeat the brush on both cervixes. Place them in separate vials that identify which cervix the sample is from, right or left, but you're using a single requisition form. And when you're collecting a sample for the vaginal vault, you're using either the broom or the plastic spatula. Do not use the endocervical brush. Collect samples from the top of the vaginal vault, making full contact. Use back and forth horizontal sweeping motions 5 times. In terms of the requisition, we're using the new OCSP requisition, as you can see on the right. In terms of the main requisition changes, the eligibility information is at the top, and the testing indications need to be checked off as well. You're going to enter your information on the top left. If another primary care provider needs a copy, enter their information. On the top right is the patient information. Ensure the patient address information is accurate. On the bottom left, for the indication, you're going to check one of the screening indications. The cytology test only option should only be selected after a previous unsatisfactory cytology result. Otherwise, should not be checked off. Now, finally, on the bottom right-hand corner, enter information that applies to the specimen, including any additional clinical information that might be relevant, i.e., do they have an IUD, are they pregnant, do they have a subsequent hysterectomy, etc. And don't forget to sign it. Digital signatures are only accepted by certified electronic medical records. So in terms of finding the new requisition, it will be available from HPV launch. It can be found on ontariohealth.ca/HPV hub. I personally don't memorize that. I just Google HPV hub. It's the first or second link, makes it super easy. All the information's there. Just remember when you're on that hub, it's the colposcopy information first, then it's the community information as primary care clinicians after that. All this information will be sent as an information package. OH is working with Ontario MD to make the requisition available through certified electronic medical records. And so contact your EMR vendor closer to HPV testing launch to explore how you can get that requisition in a digital format. All this information can also be found on the Waterloo Wellington Regional Cancer Program website. And so reasons that your requisition might be rejected: they're not eligible, it was incomplete or illegible, requisition is received without a cervical sample, the lab received duplicate requisitions, inappropriate cytology only request, i.e. only do it if you had a previous insufficient one, more than one testing indication selected, only check one, and missing testing indication, you didn't check any. So it's always important to make sure you complete the requisition properly and accurately. In terms of results, providers will receive result reports from the procured LSPs. Reports include screening results, and if positive, cytology results and the next steps. Providers will be notified of invalid HPV results, unsatisfactory cytology results, or reasons for rejection. In terms of accessing screening results history, authorized providers can access lab test orders and results from hospitals, community, and public health labs via OLIS, Ontario Laboratories Information System. OLIS can be accessed through several channels. There are some prerequisites, but there is a provincial viewer. There is integration to EMRs. You can download those tests directly into your EMR if it is integrated into your certified EMR. And we recommend that you contact your EMR provider to find out more. Patients will continue to receive their OCSP correspondence, whether that's an invitation or reminder and results. And physician-linked correspondence, which includes the name of the patient's physician on a personalized correspondence letters, will continue on. It has been shown that patients who receive a letter that has a physician-linked correspondence, i.e., if I was getting a letter, it doesn't just have a generic individual who says, please go get screened. It says that my family doctor is telling me to go get screened. It's free, and you can sign up online on Cancer Care Ontario's website. In regards to reminders, if a patient is discharged from their colposcopist, they require a follow-up in less than 5 years, then they will not receive a letter. It is up to the primary care provider who receives that letter and to remind that patient that they need a repeat test in 2 years. They will not receive a letter if they were discharged from colposcopy and required a repeat test in less than 5 years. In terms of key resources, everything can be found on the HPV Hub. This includes requisitions, instructions on how to complete the requisition, how to collect the cervical sample, FAQs, sample colposcopies and client referrals, discharge letter templates, guides to cervical screening, and guides to resuming cervical screening post-discharge from colposcopy. If you have any questions, this is the information for Ontario Health. In addition, you're welcome to email the Waterloo Wellington Regional Cancer Program, and that's their email address. Thank you. Before we go, this was a request from our Patient and Family Advisory Council for ensuring that we have trauma-informed pelvic exams and best practices for HPV-based cervical screening. It's really important to have that compassionate approach when we talk about preventive care. And so when we talk about trauma-informed care, we're looking at building safety, trustworthiness, peer support, collaboration, empowerment, and cultural competence. This is a very intimate test. This is something that a lot of folks can be afraid of. And so it's really important that there is a way of doing this in a safe way that encourages individuals to have control over their health. And so when we consider implementing screening for trauma, there are different tools that we can use, and there are different trauma screening workflows that we can use. And those are the different types of tools that we can use to help identify those individuals. And so the benefit of this is that you can encourage somebody to get more regular cervical cancer screening. It actually enhances that clinician-patient relationship by building that safety and trust, and reduces healthcare disparities by improving access to care. There are multiple resources and supports that you can make available here in the Waterloo region, including the Family Violence Project of Waterloo Region, emergency shelters, sexual assault support centers, and Ontario 211. Before we go, a couple updates in regards to the services here in the region. Waterloo Wellington has a high-grade colposcopy central referral program. Patients who are referred here approximately have a 3-week wait time until their colposcopy, and we highly encourage everyone who has a high-grade result to be referred into this program. Changes to the referral program will be made in keeping with the guidelines that are being released for HPV testing. In addition, there is a question here about vaccination. As mentioned before, vaccination is incredibly important. Just because somebody has one HPV infection does not mean that they are protected against all of them. Vaccination is still important to ensure protection and to help clear the virus. In terms of colonoscopy, we do have our coordinated colonoscopy program. So if somebody has an abnormal FIT result, please send those to our central referral program. Again, this is Waterloo Wellington wide. They're also on Ocean. This speeds up our FIT to colonoscopy time and ensures the patient gets seen immediately. And as a result, our wait times are some of the lowest in the province for people with abnormal FIT results. Finally, we have a new referral process for high-risk OBSP in Waterloo, Wellington. They are now under OCEAN, under Waterloo, Wellington high-risk OBSP listings. And so this can help to expedite information transfer and patient bookings and keeps you and your patients informed of referral status. You can still refer patients via fax if you're not on the OCEAN network, but we highly recommend using the OCEAN network as it allows for easy access for patients to get information about their status of their referral. Thank you so much.